All right, thanks, Janine. It's great to have a team of people who have their specialties and can give you guidance in different aspects of this complex disease. And along those lines, I know I've heard from the organizers that a lot of people want to hear about bowel and bladder function. And as the organizer, I passed out got my different experts to talk about the different aspects of the disease. And we do actually have an expert at UT Southwestern on bowel and bladder, about bladder issues, a neurourologist, Dr. Gary Lamack. Unfortunately, he was out of town. So I've learned a lot from working with him on patients with bladder problems in the context of neurological diseases. But this is a big issue, and it's tough to find colleagues that can help us. For the neurologists taking care of patients with MSA, there are certainly urologists out there who deal with urinary problems, but not too many neurourologists who have a concept of what goes on when it's not so much the bladder as the nervous system control of the bladder, the autonomic nerves. And the same with bowel problems. We've heard from the other speakers that constipation is almost a universal problem, and other bowel problems. But your neighborhood gastroenterologist doesn't have much interest in sort of helping out with these things. They want to do your colonoscopy and make sure you don't have any polyps. But when it comes to trying to managing these difficult bowel problems, we kind of have to develop our own methods, and a lot of this we learn, of course, from our patients as well. So I'm gonna tackle these issues, and also just a couple words about sexual function at the end. All right. So the autonomic nervous system is affected in MSA. That's one of the hallmarks of the disease, and it may happen early, it may happen late, but the autonomic nervous system will be affected. And we've heard about orthostatic hypotension. That's sort of obvious and easy to kind of get a handle on. But sexual dysfunction is extremely common. Over 90% of men will have erectile dysfunction, usually early on in the disease. Constipation, almost always present to varying degrees. Sometimes it's a major problem, but it's always there to some degree. And then the urinary symptoms, which start off small and eventually become a major issue. In fact, some of the diagnostic criteria often mention early urinary bladder problems as a hallmark of MSA, a clue, a red flag, as Dr. Chitna said, that this isn't run-of-the-mill Parkinson's disease, but something else. So why does this happen? Here's a little map of the autonomic nervous system, well, part of it anyway. This is the parasympathetic nervous system. This just shows that there's some nerves that come out of the brain stem, the upper part of the nervous system, and those nerves go out to control a lot of important things, including this big long nerve called the vagus nerve that comes down and connects to a lot of different organs, but importantly connects to the stomach and the intestines, and is responsible for helping those things work properly. And then way down here at the bottom of the spinal cord, we call the sacral part of the spinal cord, there's a bunch of neurons, nerve cells, that are specifically involved in autonomic function. And this sacral nucleus of the spinal cord is the one that sends out the information to the sphincters, the bladder sphincter and the rectal sphincter, and to the sexual organs. So this is where, although it's way down at the bottom of the nervous system, this is where a lot of important stuff happens. And what exactly happens, you heard about glial cytoplasmic inclusions. You've got these nasty accumulations of proteins, including alpha-synuclein, one of the proteins that builds up in these neurons and eventually kills them. And so if you lose the neurons, the nerve cells down here that are supposed to be controlling the sphincters and the sexual function, then of course those things don't work properly. So let's start with the bladder. The bladder's more complicated than one might think, but I simplified it by narrowing it down to two muscles of the bladder that are important. You've got a muscle of the bladder wall, the detrusor muscle, which is basically the muscle that squeezes the urine out when it's time to urinate. And you've got a muscle here called the sphincter. It's basically the valve. The sphincter muscle squeezes to keep the urine in, and needs to relax when it's time to urinate. So what happens when the nerves that control the bladder aren't working anymore? Well, you get a weak squeeze muscle, so you can't squeeze the urine out. The bladder becomes weak, and therefore there's something called urinary retention. So you urinate, you think that you've got it emptied, but in actual fact, the bladder still has a lot of urine in it. And then there's loss of sphincter control, which can go either way. Sometimes the sphincter won't relax, which contributes to urinary retention, also causes hesitancy, trouble getting things started. But there could also be the urinary sphincter that is too weak. It doesn't stay closed. And so as the bladder gets full, instead of giving you time to make it to the bathroom, the sphincter's not weak enough to hold it in, and things start to leak. That's incontinence. So it starts as urgency. You have to get there quickly because the sphincter doesn't hold. And then eventually even incontinence, where things just leak out without any warning at all. Okay, so I just sort of thought about this and made a little timeline here of what generally happens in MSA. Oftentimes, early on in the disease, there's urgency and frequency. And I don't think we need definitions of those terms. Everyone kind of has a flavor of that. So urgency means you don't have much time from the time you get the warning that your bladder needs to be emptied till it's going to empty on its own if you don't get to the restroom. And frequency means you empty your bladder, and then a few hours later you feel like, I've got to empty my bladder again. And why does that happen? It's probably early sign of retention. You're not getting it all the way emptied. So after a while, it's already starting to fill up again. And the other thing that happens early is nocturia, or nighttime urination, that you try to empty your bladder up before you go to bed, but then during the night, you feel like it's waking you up, you got to go some more. Those things kind of go together. Hesitancy, I mentioned, trouble getting it started, so you get the urge, you rush to the bathroom, get all set up, and can't feel like nothing's happening. Know your bladder's full, trying to get it started. Again, a combination of a problem with the sphincter and the bladder muscle. And then as time goes by, you get frank retention, that you can demonstrate that the bladder is not emptying fully. And that can be measured in a number of different ways in the clinic. Either they can have you urinate, try to get everything out you can, and they could do an ultrasound, see how much is left in the bladder, or even use a catheter to drain the bladder and see how much was still in there. And generally this means that those bladder muscles are getting weaker. And then as time goes by, the bladder starts to fail even more, and you get incontinence, leakage. And this can happen for a number of reasons. One is that the sphincter is weak enough that it really can't hold anything back, and it leaks. But more often than not, in MSA patients, it's what we call overflow incontinence, that the bladder gets full and full and full, and eventually it just starts to overflow. It's full enough that things start to leak out. And even after you've emptied as best you can, it's still full enough that some can continue to leak. And we get to those points, and the ultimate thing that will often happen, or I guess, to be honest, will happen, is that catheterization at some point is necessary. That to avoid the problem of incontinence and the problem of retention, the bladder has to be emptied, and the most straightforward way to do that is to put a catheter in and let it drain. Okay, so urinary retention is the thing we're concerned about, and that's measured as something called the post-void residual. So your urologist may mention this term to you, which means how much is left in the bladder when you're done voiding or urinating. And if there's a post-void residual, you'll have the sense of frequency, that you still feel the urge even after you've urinated, and you'll need to go frequently. And maybe you feel like your bladder was pretty full, but when you urinate, it's not very much that comes out. You say, well, that was interesting. I really felt like I had a full bladder. And then you'll feel like you have to go again, because it really was full, and you just weren't able to empty it. So one number that's often used in the literature by the urologists, if they consistently find that after you urinate there's still 100 milliliters, that's a tenth of a liter, that's still in the bladder, then you're at the point where you need catheterization. So why do we care that the bladder's full and you can't get it emptied? Well, an overfull bladder can cause problems, not only incontinence, like I mentioned, but if the bladder's full and there's pressure in there, the pressure then is transmitted back up to the kidneys, and that pressure on the kidneys can actually cause kidney damage if it persists. The overflow incontinence, as I mentioned. And then if you have that urine just sitting there not emptying, bladder infections can happen too. So there's consequences. People like to put off that decision about catheterization, but there are significant consequences if you do. And also, this is a tricky business. Neurologists, especially if they're thinking more about Parkinson's disease, they haven't quite started thinking about the diagnosis of MSA, may not recognize these bladder problems. And even if you end up at a urologist, which a lot of patients do, they may not get the diagnosis right to start with. Bladder symptoms can be the first sign of MSA, and people may not put 2 to 2 together. I'm having bladder problems and I'm kind of moving slowly. So about 50% of the time, men who have MSA get diagnosed as having prostate enlargement, because that's way more common than MSA. And they often get treated with various medications or even a surgery to try to open up the urinary flow, which usually doesn't help very much. Women may be just diagnosed as having stress incontinence. Maybe they've had a few children and they say, well, that's just par for the course. Sorry about that. But in actual fact, it may be the early signs that there's a bladder problem and this is MSA. I won't say that surgery never helps. Sometimes people do have prostate enlargement at the same time as MSA and may in fact need surgery, but that needs to be considered in the context of the diagnosis. So what about, there are lots of bladder medications. You probably see the commercials on TV, various medications you can take. And I'll talk about them in a minute. They may work early on. They may only work partially. But there's a problem that there are other symptoms, as in the case with the other medicines you heard about, that other symptoms can be worse as you're trying to use medicines to treat the bladder problems. So in addition to medications, we need to think about behavioral management. And just like Dr. McPitty was talking about non-pharmacological treatment of blood pressure, there's non-pharmacologic treatment of the bladder. And these are really the most important things to use either on their own or in combination with medications. So early on, if the problem is nighttime frequency or wetting the bed at night, there's obvious things you can do. We're always telling you, drink lots of fluids, liters and liters of fluids all day long. That's true. That's what you need to do that. But you should try to plan your day so that you get the fluids in early. Start drinking right in the morning. And then as you get past dinner and you're coming toward bedtime, you need to start cutting back on the fluids. You don't want to be drinking 2 liters right before bed because that's going to end up in your bladder. So that's important to think about that and not be behind the ball so that you're trying to catch up on your fluids while bedtime is coming at the same time. You've heard that you need to elevate the head of the bed. That's important for so many reasons. It helps with orthostatic hypotension, helps reduce hypertension, but it also will help with the bladder issue because you'll make less urine at night if your head is elevated, and that'll be good. So what about this frequency issue and retention? It's important to kind of plan and think about urination. Again, we're talking about autonomic features that you hope to go through your whole life and never have to think about your autonomic nervous system because it's supposed to do its thing. But now you have to think about timing your voiding, so planning some times during the day when you're going to go and urinate, try to empty the bladder so that you don't let it get so full that it can't empty. Reducing caffeine intake. Caffeine can be good for some things, but it tends to make the bladder wall kind of feel a little bit more spastic and can make you have that frequency feeling. It's dependent on the person. You can try reducing the caffeine intake. And then as far as bladder retention, again, timed voiding to try to keep it empty so it doesn't have a chance to fill. But also there's some techniques that can be used to kind of stimulate as you're trying to empty the bladder to get it to go. Some massaging of the lower abdomen or even tapping on the just above the pelvis to try to stimulate the bladder to constrict, even though it's not getting the signals from the nervous system. Sometimes locally you can get the bladder to do its thing. And there's various relaxations, physical therapy techniques that can help to relax the sphincter and help the bladder contract. One thing that often happens is when you're struggling to urinate, you get anxious and you get the sympathetic nervous system turned on more than the parasympathetic nervous system, and its job is to keep the bladder from emptying. So the more you get frustrated, the less likely you are going to get a good emptying of the bladder. So again, a timed schedule and some relaxation so you have a good sense of it. What about drugs? Most of the bladder drugs that are out on the market, you may recognize some of these names up here, are what we call antimuscarinic drugs. So they're basically bladder relaxants. So people take these medicines because they have a quote unquote overactive bladder. And these are really not the medicines that we want to use in MSA, where the bladder is not having a problem with being spastic. It's actually too weak. So these medicines, and you can see the ones there that are, I often see MSA patients take a trip to the urologist and come back on one of these medicines. The problem is they can actually increase retention, increase constipation, and make orthostatic hypotension worse. So best to avoid them. Now, early on in the disease, sometimes they are somewhat helpful, but there's a different class of bladder medicines. If you're going to use one, the other class are called the anti-adrenergic drugs, and those include Flomax and Hytrin, and these are the ones that the men often get if they think they have some prostate enlargement. And there's actually been a few studies that show that they can help to reduce bladder volume and obstruction in MSA patients for up to 2 years. So again, they work early, and then they sort of lose their effectiveness like most medications do. But with the caveat that they can also make the blood pressure lower. So that's a problem. So be aware of that. And then at the bottom, if nighttime bladder problems are the biggest issue, then sometimes we'll try to use a medicine called desmopressin, or DDAVP, which is actually a hormone that tells the bladder to stop, tells the kidneys to stop making urine. Now that's not necessarily something you want to do. You want your kidneys to work properly. But you can use DDAVP at bedtime if nighttime urination is a big problem, to reduce the urine production during the night. The important thing is you only use this medicine at night, and hopefully get you a little longer through the night without having to get up and empty the bladder. And then when you get up in the morning, start your fluids, make sure you get the kidneys jump started and working again. So it's not meant to, we don't want to reduce urine flow. In fact, oftentimes I have to counsel patients because they come in and say, have you been drinking your fluids like we told you? And they'll say, well, no, I haven't, because the more I drink, the more I got to go to the bathroom, and that's a problem. And so one thing leads to another. We have to really help reinforce the idea that they have lots of fluids going in, and you just have to coordinate the bladder so that you make sure it gets emptied, even though you're putting a lot more fluid through the system. Well, what happens next? Eventually, the catheter comes along, because ultimately the nervous system is degenerating and the signals aren't getting through, and no medications can fix that as far as the bladder goes. So intermittent catheterization really is the most reliable way under those circumstances to get the bladder consistently emptied. And again, working with the urologist, you can decide when that happens and whether it's at 100 milliliters of post-void residual or what have you, is when you start thinking about intermittent catheterization. So it needs to be scheduled so that the bladder stays emptied, and that prevents retention, prevents kidney damage, prevents incontinence, because the bladder's empty, you can't have incontinence. And really, there's lots of studies that show that intermittent catheterization is better than just putting in a permanent catheter because of issues of infection and other things. So most MSA patients will eventually get to this point, and it seems like a terrible milestone, but I've had plenty of patients who say, boy, why did I wait that long? Now, it's a pain, I don't like it, but there's a lot of other things that are better now that we're using the catheter. Okay, so that's the bladder. What about this thing, the colon? So the colon has a sphincter, and it's also controlled by those nerves. And there's the smooth muscle of the bowel wall, which is responsible for moving things along. And again, just like in the bladder, both of these things are affected. In fact, the bowel, like the colon, actually has its own nervous system with its own neurons in the wall of the bowel that coordinate some of this stuff, but then there's external control. Unfortunately, those neurons within the bowel themselves are also involved in the pathological process of MSA, and they start to degenerate as well. So as a result, the smooth muscle, the peristalsis, the waves of movement that keep things moving, slow down, just like all the other motor functions slow down. And then there's some trouble with the sphincter control. Again, both trouble relaxing the sphincter or trouble with the sphincter not relaxing and difficulty getting things started. So the earliest symptom is constipation, that the bowel movements are slower and it's more difficult, and even patients who get frankly impacted and have to go in for management of that. So really the goal is to ensure a regular bowel movement so that we don't get to that point. How do you do it? Again, things you do besides medicines are going to be more important. Again, lots of fluids. I think you've got the point. Lots of fluids is going to be important. Frequent small meals, as before, that are high in fiber and not high in baked goods and starches and things that tend to slow the bowel down. So that means lots of vegetables. Most fruits are high in fiber, except for bananas. For whatever reason, bananas cause constipation. And you probably, if you're taking Florinef, I've heard you need to get extra potassium, and maybe bananas would be good. But in fact, bananas may be fine, but in some patients, they kind of slows down the bowel a little bit. So avoid those things. High fiber diet. Exercise is important. Just moving around, the movement of the body will help move the bowels along. So it's important. I think, as Dr. Kamani was saying, immobility leads to a lot of problems and an exacerbation of a lot of things, including the constipation. And then we need to check other medicines. Patients, as they're getting older, have other problems, not only all the problems associated with MSA, but they may be on a lot of other medicines. And constipation is a common side effect of a lot of things, including pain medicines, antidepressants, the bladder medicines I talked about. Even some of the supplements like calcium and potassium supplements can slow the bowel down somewhat. So you just have to look at those with your doctors and kind of coordinate things so we understand that those medicines have a role, and that we understand that the side effects have to be considered too. Okay, so if you need to use some medications, we generally like to start with non-stimulating medications like fiber supplements. Getting a lot of fiber in your diet is difficult, so supplementing is important, or using a stool softener like Colace or Docusate. Those things are available over the counter. And again, bulking up the stool, keeping it soft so that the bowel doesn't have to work so hard to move it through. Some patients need a little bit more help, and we like to move on to sort of laxative type medications. So polyethylene glycol or Miralax or various other generic names, again, available over the counter nowadays, is basically a medication that keeps a lot of the fluids in the bowel, so that, again, keeps the bowel soft, keeps it moving along. This is the same stuff that if you ever have a colonoscopy, they give you a big jug of it to drink because it really moves things along nicely. But now a lot of patients with Parkinson's disease or MSA can take a daily dose of Miralax, and that keeps things much more easy to manage. A stronger one is called lactulose, same idea, but a little bit stronger. That one's a prescription medication. And then if you need to stimulate motility and you need something a little bit stronger, we sometimes will try some cholinergic drugs like the pyristigmine that Dr. Mupiti mentioned, which is basically an autonomic stimulant, or other cholinergic medications. And really, laxatives like Dopalax or enemas, really a last resort. You want to try to avoid getting to the point where you're having to use those sorts of things. By using the other techniques and the other sorts of medicines to prevent the point where you haven't had a bowel movement 3 or 4 days and you're stuck with needing to use a stronger laxative. And why? Because the bowel causes a vasodilation in the sexual organs, but in other places as well. So that means that one of the listed side effects, and when you hear the commercials, they'll also tell you these medicines can cause an unsafe drop in blood pressure. Right? You hear that hear it all the time on TV. So you're already an MSA patient that has troubles with low blood pressure. This can cause an even bigger problem with orthostatic drop in pressure. But we have to understand quality of life is important. So I'll work with my patients often and let them understand the potential risks involved. But there are ways to manage sexual activity, assuming that one of these medications does work. Remember that the effects can last for a few hours, so you're probably not going to be up and around, because when you're up and walking around, the blood pressure can be pretty low. And for that reason, there's one of these that's a longer acting one, Cialis, that's probably best to be avoided because it can cause a drop in blood pressure that lasts for many more hours. Sexual dysfunction probably occurs in women too. That's really harder to figure out whether it's present or what to do about it. And I'll take the liberty of not addressing that issue. So that's what I had to say. I know it's been a long morning, and we have question and answer sessions. We'll get the whole panel up here after lunch, I believe. But I'll turn it back over to Judy right now, and then move on to lunch. Thanks.